Good morning. I'm Dr. Ara Deuk, CEO and founder of the Deuk Spine Institute here in Florida, the United States of America. We are going to be broadcasting live, streaming the Deuk laser disc repair procedure. This is a state-of-the-art spine surgery that's used to treat herniated discs in the neck and back, causing back pain, neck pain, arm and leg pain. This procedure has been around for 13 years. It's been peer-reviewed and published in the United States by neurosurgeons, published in Surgical Neurology International. It's an online medical journal, very reputable. Dr. Jim Osman, Professor Emeritus, former chairman at UCLA, the editor-in-chief, and we published originally in 2012 on the technique, and then 2013 on results. I've since then published at many meetings additional results with the procedure. Today we're going to be treating a patient who didn't want to have a cervical fusion or artificial disc put in. This patient has herniated disc causing symptoms at C5-6 and C6-7. Right now our patient is asleep under general endotracheal anesthesia, fully relaxed. Good, good. All right, we've already done our timeout. And I'm going to be palpating the neck right now.
Yes, sir.
Okay, around the carotid. Feels subtle. Thank you. I feel the spine quite well.
Lights off, please.
And we have Dr. Calcarnia here today, our anesthesiologist.
Hello,
Hello.
everybody.
Shot. We're going to be radiating, so, all right, 2, 3, 4, 5, 6. Huh?
Sorry for that.
So, shot. 2, 3, 4, 5, 6, 7. Everybody's in agreement, right? 6, 7. Shot. I may need a shoulder pull. All right. Just a shoulder pull. Shot.
Oh, shoulder pull.
Not you.
Oh,
You can do some inline traction. Shot. Just a little bit. Shot. All right. AP now, quickly.
neck traction?
You don't need to do anything.
Okay.
Don't worry about it. We're lucky. His neck is good neck.
Long, yeah.
Just a quick AP. This is super quick. All right. That looks like I'm a little bit off to the opposite side, but not bad. Coker. Shot. Aha. All right. Coming out. Shot. That looks great. Lateral. Does he have a skin tag?
Make sure it's down.
Perfect. So this is probably the second hardest part of the surgery. Shot. All right, 2, 3, 4, 5, 6, 7. Everyone agree? 6, 7. Luis, you agree? All right, at this point I've got my needle in the C6-7. You can relax. Thank you. What was that? Everything okay? Oh, we have our laser rep here too. Shot. And tell me your name again. Nicole. Nicole, nice to see you. Thank you for being here. Is everything okay at home? Shot. All right, give me a shoulder pull one more time. Luis, grab a shoulder here. Grab a shoulder and push. No, your hand can't be that high. Put it on the ball and push down. Shot. Very good. So you can see the dye leaking out through a tear in the back of the disc, going to the epidural space, going around the nerve root. That is 2, 3, 4, 5, 6, 7. Perfect. All right, let's get an AP shot real quick. Coker. Take your time. You get to have a nice AP. Line it up. So our patient, unlike the lower back Deuk laser disc repair for the lumbar spine, our patient's fully asleep under general endotracheal anesthesia. That's perfect, thanks. Go back to a lateral view. Our patient's intubated on the ventilator and fully relaxed. Blood pressure's good.
Blood pressure is good, 110, 114 over 60.
All right, let's try to bring it down just a little bit into the 80s to 90s. Actually, you can keep it there for now if you'd like, while I do this. Yeah, shot. Very good. So I'll need just another shoulder pull shot. No, don't move while the fluoro's on. Shot. That's good. Shot. Looks good. So for those of you wondering, what are you doing? Well, what I'm doing here is I'm treating herniated discs. What's the traditional old-fashioned way of treating herniated disc? Spinal fusion. Spinal fusion, a procedure called an anterior cervical discectomy and fusion, epinephrine.
Yes.
And that procedure has been done for about 100 years. It's basically cleaning the discs out and putting in a spacer or a cage and then fusing the bones together so they don't move anymore. And what's quite interesting is that spinal fusions have been done for a long time for symptomatic discs. Artificial discs have sort of started to become more popular over the last 30 years. But in the United States, they've been approved by the FDA only more recently, in the last 15 years. Now, the endoscopic surgeries were done first, from my understanding, in Korea. The Koreans started doing this surgery first, and there's another doctor, Dr. Joe, in the United States, who does a similar anterior approach, but he doesn't do the same thing I do. He does some very different stuff. And the differences are significant and, in my opinion, much worse. He goes, I think, through the bone, and his results are not quite as good, and I don't even know if he's doing the procedure anymore. But that's really the only surgeon in the United States that did an anterior cervical endoscopic type surgery, Dr. Joe. And then myself. We're the only surgeons in the U.S., and right now, I'm the only surgeon in the U.S. doing this surgery. And the reason for that is it's too advanced for other spine surgeons to do. They don't know how to do it. They haven't been trained on it. They don't have the equipment to do it. They don't have the experience and expertise to do it. But this surgery you're watching will eventually take the place of fusion surgeries in the neck and artificial disc surgeries in the neck. Shot? The reason why it's not more popular or common is because surgeons don't know how to do it. But this is truly the most advanced surgery in the world for herniated discs in the neck and back. Shot? All right, very good. Shot? Okay. So let's get an AP. Coker. So what I'm doing now is I've placed a needle into the disc, and now I've placed a guide wire through the needle, and now I'm bringing the tubular retractor and the dilator, then tubular retractor down into the disc space. Okay? All right, go back to a lateral. So we're a little bit off midline, but we're acceptable. And there's basically a space in the midline between the longest coli muscle. And that's where we are. We're just on the border of the longest coli muscle. And the reason we're off to the left a little bit is that this patient's left arm is the problem. So we actually approach it through the opposite side. Here you go. Mallet, shot. Shot. Mike, I might need a pull in a second. Shot. Yeah, that would be helpful. Shot. Very good. So I'm making my way with the tip of the dilator through the disc. We're leaving the front of the disc alone completely, and we're just making our way to where the herniation is and the bone spur is in the back. Shot. That's perfect. So every surgeon that does anterior cervical decompression and fusion has the goal of getting rid of the piece of the disc that's squeezed out backwards that's pinching the nerve or spinal cord. That's our goal. And for the last 100 years with ACDF, we've had to take the front of the disc out in order to see the back of the disc where the herniation is, using a microscope or loops, surgical loops, which are magnifiers. Shot. But the Koreans were really the first to say, hey, why don't we do endoscopic surgery, just like we do for shoulders or knees? And let's bring a tiny tube in through the joint and find the part in the back of the joint that's causing the problem, which is the herniation in the back. So they developed this instrumentation, which I learned on from the Koreans 13, 14 years ago now. And I took their technique and I improved on it. And one of the things I did differently than them was that they would keep their patients awake for the surgery.
Yes, I've done thyroids under cervical.
Yeah, but when you're on top of the spinal cord with the patient awake,
Patient can
shot.
tell you it's herniated.
That's exactly why they keep the patient awake. So the patient can tell them when their arm pain went away. I don't need the patient to be awake to know their arm pain is going to go away. I mean, and honestly, what I saw with their surgery was the patient would be thrashing around, moving during the whole surgery. It's dangerous because you have to be fully relaxed, in my opinion, fully relaxed to palpate the spine with your fingertips. And if you don't get your fingertips on the front of the spine, then you have soft tissue between where you're entering the skin and the spine. You could hit the carotid artery or jugular vein or the esophagus. And I've never had a complication from this surgery in 13 years. And I think a large part of it is the patient isn't moving, so there's no moving target, plus the neck is extremely supple because they're fully relaxed. The Koreans didn't have them. They would tighten up their neck, tighten up their body, wiggle around. So of course they had some complications. And the patients were paralyzed or strokes from their surgeries. And all you have to do is put the patient asleep.
We have quick in, quick out drugs, so we can do just as good of a job as
Oh yeah, much better. I would never do this surgery with the patient awake, never. Oh yeah, no, it's horrible. The one they broadcasted live that I saw from Korea, the patient was wiggling around the table, trying to get off the table during the surgery, in pain. Oh yeah, it's crazy. That's why they stopped doing it, because of the complications. All right, so at this point we've got our working channel or tubular retractor inside the back of the disc, and I'm bringing in the laser fiber. We're overexposed, so I need the lights down a little bit. Let's bring it down a couple of clicks. One more. That's probably good right there. Thank you. All right, and what we're looking at right here with the endoscope is the herniation. It's the base of the herniation. So we're going to use the laser fiber. You can see the laser fiber there. And we're going to basically zap out the herniation. Now this is not an IDET procedure, intradiscal electrothermoplasty. An IDET is a blind procedure done through a needle. We're not working in a needle. We're working through an endoscopic cannula. So this is true surgery, and it should only really be done by trained surgeons. And the training for this is a whole year of training with me, if you want to learn how to do this. So surgeons that are watching this right now should not try to do these surgeries without undergoing proper training. That's my advice. Proper training by a surgeon who's experienced in the technique, experience with managing any potential complications. All right, so there's a herniation right there. And I'm going to try to grab it out with the grabber. We have a little metal grabber that has a long stem, and it's called the pituitary. What's going on?
Good, I'm just checking the connectors.
Oh, look at that herniation. So let's get a light on here. I'll show you one of the herniations that came out. OR light on. Can you see this, Sean? Nice, Luis. Good job.
Yes, we can.
So you see the herniation is stained blue. Here. Yeah.
Light's a little bit overexposed.
A lot of air. Michael, can we call Michael, please?
Where's Michael? Mike's here. Come on over, Mike.
My cup looks good.
Scope off.
Do we maybe have a
Do we have a scope? Whatever you need.
Michael? I'm losing air here. The tube looks good. I need some air.
Let's get a chest x-ray real quick.
No, I just need
You want to check positioning?
my cup is okay, doctor. It's not I mean,
You're not interfering with me. I'm just going to wait, though, until you're ready. Go ahead and move the fluoro into position.
okay, I'm good. I just needed to put a little bit more air.
That's fine, but let's get a chest x-ray,
Problems?
just so she can see. I can't see. You're zoomed in too far. You're going to have to zoom out a little bit. Make your field bigger if you can. That's good. Let's see if we can find that ET tube. You have to go north a little bit. Doctor, are you happy with that?
I am happy, doctor. Please go ahead.
You
Call
see the x-ray? Are you happy?
I am, let's see, good.
Looks like you're above the main
There right now.
split to me. Okay, so we can proceed?
Yes, doctor, thank you.
All right.
Thank you for waiting.
Yeah, of course. So go ahead and go back to the lateral view. So as a surgeon, you always have to work carefully with your anesthesiologist. And the anesthesiologist is really responsible for the cardiovascular system, breathing, circulation, and really the stability of the patient. And so if they're concerned about anything, you need to do everything you can to help them resolve the issue, because for the patient's safety. You don't just ignore them. You have to heed them and help them. So whenever my anesthesiologist has a concern, I always stop what I'm doing and I do everything I can to assist. And then when we're safe to proceed, I proceed. All right, so we're back in the herniation. We just took a big chunk out, and we're going to try to remove some more using the laser. So right now it's kind of hard to see what's going on, and because I have a lot of experience doing these, I know exactly where I am. And that's kind of a bone spur up there at 11 o'clock. And there's another herniation right here. And what I'm going to try to do is free up these herniations so I can pull them out with the pituitaries. But long story short, I don't know for those of you who are watching if you can understand what we're doing. When a patient has a herniated disc in their neck or back, 95% of the disc is fine. It's not causing any problems. It's only 5% that's the problem area. And it's the 5% that's in the back. And so traditionally the way we there's a herniation right there. You see that come out? Pretty cool, huh? It's called a reverse herniation. I coined that in our publication in 2012 for the first time ever in medicine. A reverse herniation is when the herniation or the nucleus material comes back into the disc. Since we're inside the disc, you can see it re-enter the disc. And it herniated out as part of this patient's problem when he had his neck injury, but now we made it come back into the disc, so we call it a reverse herniation. And that way we can get out the pieces safely from inside the disc rather than inside the epidural space. So what I was getting at is the reason the Koreans developed this surgery was because they realized that if you could go in and remove a herniation in the back of the disc, the little piece that's sticking out, causing all the problems, without taking the whole disc out, then you don't need to do a fusion. you don't need to do an artificial disc. You don't need to do a fusion or an artificial disc. Basically, you maintain stability of the segment by not removing all that disc material up front. But see, I was trained at the best neurosurgery program in the country at the time. It was University of Florida in Gainesville with Dr. Roten. And we're all trained to take the whole disc out, 100% of it, and then fuse it. Or put an artificial disc in. There's another fragment. Long story short, the only reason you're doing the fusion and putting a cage in, a metal plate in, is because you took the whole disc out. Well, if you don't take the whole disc out, you don't need to do any of that. So the Koreans figured that out and figured out a way to get into the disc and remove the herniation without taking the whole disc out in front. And they did that arthroscopically. And so I learned this arthroscopic technique from them, and I changed what they did and made it better. I made a lot of changes and made it much better. And my results are better than they ever had, than anyone in the world has ever had. And the complication rate is 0, which nobody else has a complication rate of 0. So the Deuk laser disc repair is the only anterior cervical endoscopic surgery with a complication rate of 0. There's another herniation. Stand by. In 2019, after 13 years of doing this procedure, 0 complications. You have it there. So that's pretty remarkable. There's no other spine surgery in the world with 0 complications, especially after 1,000 procedures. And I've done 1,000 of these surgeries. Have you ever seen anything like this before? Dr. Kalkarni? You've traveled the world?
No.
Right, you have not. And that's because nobody else in the world does this.
What about Tampa?
Tampa? No. Laser Spine Institute? They went out of business. But when they did cervical, they went through the back of the neck. They did a foraminotomy. Nobody else does anterior cervical except for Dr. Joe, myself. And Dr. Joe goes through the bone.
Why?
It's his technique is bad. I would never do that. There's no reason to do it. Very bloody.
Bleed,
Yeah, it's a mess. This is very simple, and it works. It's elegant. You can ask all the questions you want.
What, since I have this herniated disc, what's the recurrence rate of herniation?
Yeah, the recurrence rate of herniation that's symptomatic and requires treatment is 1%.
Okay.
1% for this surgery. So what Dr. Kalkarni has asked me is, all right, so maybe this is successful, but does it really last, or do people get recurrent herniations? And the recurrent herniation rate is 1%, which is actually very good for a disc type surgery without fusion. The recurrent herniation rate for microdiscectomy is around 25%, in my experience, from what I've seen.
You're not thinning out the existing disc, right? You're just taking out what's herniated.
That's correct. So we passed the normal disc up front, and it's not even normal, it's still degenerated, but it's not causing symptoms. So think about it as the asymptomatic part of the disc versus the symptomatic part. The symptomatic part is this foraminal herniation right here. That's the foramen right there. And we just took out a chunk of herniation from the foramen, and there's probably a few more pieces we can get out, like right here. But we're just underneath the exiting nerve root right here.
You can see the nerve root.
I know where the nerve root is because I've done so many of these and I know my anatomy very well. That's why Dr. Roten picked me. Even though I was from California. He doesn't like Californians. He picked me because I'm a neuroanatomist like him.
So now, why are you going to the other side?
Because you can get over, so if the patient has a left-sided herniation that's symptomatic, going from the right side of the neck, the angle is better, the trajectory is better, contralateral.
So you're just going through the foramen.
Look right here, that's the foramen. There's a piece of herniation right there.
Going across.
I'm going across. Now I can get both sides, but it's easier to get the opposite foramen from your approach. So,
What are some of the structures that you're passing through when you go across?
yeah, so the structures that I'm passing by
Passing by.
as I go across,
Space or
Well, so I have the skin, right? The subcutaneous tissue, the platysma muscle. There's a herniation right there. It just came out. Under the platysma muscle, then you're going to have the sternocleidomastoid. Stand by. Stand by laser. Let me try to grab it out. And I'm going to go medial to the sternocleidomastoid and lateral to the strap muscles and the thyroid. And then the carotid sheath and its contents, like the jugular vein, vagus, I'm going medial to them, between them and the esophagus and trachea. So there's a millimeter plane, and I'm going right through that millimeter plane. It's pretty incredible. Yeah, but that's why nobody else does it, because it's you know, you have to know what you're doing. So, yeah, it is amazing. So the reason, and one of the reasons I talk to my viewers as to why this surgery isn't more prevalent is the way surgeons learn how to do surgeries is driven by industry. So the companies that manufacture the metal plates and cages and screws and rods, they actually support residency training programs financially and provide training for the residents on how to do instrumentation. And in the years gone by, that was great. You know, it was a benefit to everybody, right? Residents got trained, programs got support. But the truth is that this surgery you're watching now, we don't put any implants or metal in. So there's no manufacturing of any product that gets implanted. And therefore, there's no company that's incentivized to train the residents during residency. These big companies like Medtronic, Deuk, that manufacture Alphatec, Nuvasive, they quite literally will spend hundreds of millions of dollars a year training residents how to use their products, so that when they get done, they go out and they operate on patients and use their metal, their implants. And so, of course, that's what the residents do. They go out and they put all this metal in people, in their spines, because that's what they've been trained to do, because that's what the industry supports. They come in and train these residents. Well, that's why this procedure has not gained popularity, because there is no money to be made by the industry. They can sell the scopes, they can sell the laser fiber, but their sales are so minimal. They don't have those big margins. So they can't really help train the future generations of spine surgeons the way that the metal companies can. So the metal companies are dominating spine right now. And I do metal implants as well as a surgeon. I'm trained to do all of it. But this is a much better surgery for patients rather than putting metal in them. And the problem is that to train surgeons to do this, they would have to spend time with me. The company would have to take them out of their work, and it gets very expensive. So it's basically cost prohibitive just to train surgeons how to do this procedure. I have an open invitation for a fellowship, and the problem is that a surgeon would have to literally take a year out of their life to come and train with me to be able to do this procedure. And most surgeons don't want to spend a year out of their life training after they've just done 7 years of training. So the problem is this training is not happening during their residency. That's where it really needs to happen, during residency. And if they don't learn during residency, they're not going to learn it at all. The only reason I learned it was I'm more motivated to advance medicine than I am to, literally to make money. That's really what it comes down to. So I took time out of my schedule. I stopped making money while I learned this technique.
Your brother is a neurosurgeon.
Yeah, my brother's a neurosurgeon. I'm getting a question. Has anyone from South Korea expressed an interest in coming here? So the doctors I trained with, the way that surgery is done in other countries, like particularly Asian countries, is that they have this hierarchy of surgeons. And basically, there's like a very strong pecking order among surgeons, and the top surgeons over there run everything. And the lower surgeons just wait for that top surgeon to die so that they can fill his position. And it is a him usually, because they don't train women usually. But those top surgeons would never come over here to train with me, because they would be showing quote unquote weakness, so to speak. Right? It,
Asia exists, they, I don't know, less realization that every day is a learning,
right?
especially, things are advancing. I don't know if I told you, I used open ether. I did anesthesia in India for
Uh-huh.
2.5 years. And we would use trichloroethylene, which is, ether is very pungent.
Uh-huh.
Trichloroethylene is highly cardiotoxic. So you give few whiffs, and the pumps would go away, and then take it over with ether, which is a sympathetic stimulator. So
Okay.
if I told you, hey, I'm going to use ether,
Watch the
you
cable on my
would
face.
say, get out of here.
Like if you told me you were going to use ether here,
Yeah, so
I would say get out of here.
In other words, anesthesia has evolved
Oh yeah.
tremendously, so we have to be open-minded. Otherwise,
It's evolved in the United States, you mean?
even in India,
Really?
tremendously, because I don't want to tell you the year. This was in late early 80s.
Yeah, anesthesia has evolved.
Oh, tremendously.
It's allowed us to do these kind of surgeries outpatient.
Exactly.
Yeah.
Even cardiac surgery, which I did,
Yeah, yeah.
they come on the same day, they like it.
Oh,
Patients
yeah.
like it, not getting admitted.
Yeah. I mean, you can repair a PFO outpatient now, right?
That I don't know.
Pretty
Only
much.
thing, interventional.
Yeah.
Yeah. My husband had that.
Really?
He had a stroke.
Oh, no
He
way.
got very,
Where did he have his PFO repaired?
in US.
At UF.
Yeah. He's
There's a good surgeon there?
interventional. Doctor, he was totally pediatric interventional. He left long time ago.
So mostly kids have that PFO repaired?
Most
Not so much
common,
adults?
I think, but apparently, he had motor area because his left side, but he's completely recovered and
Yeah,
went
that's
to work
awesome.
in 3 weeks. It was scary.
Oh, sure, of course it is.
Talking about devices, the influencer or something, they don't give unless there is 2 episodes of stroke.
Who doesn't give?
The
They don't give
company
what?
that makes it.
They don't give the PFO
No, they don't.
repair
No, first time they have to have the second time stroke. And
for a
then-
PFO
Yeah.
in India.
No, here.
No way.
Yes, way.
They make you have 2 strokes before they close it?
Yeah.
That's crazy.
Yeah.
I would never tolerate that.
We were prepared to give 18,000, I think, but worked around, and I just don't understand.
All right, so yeah, so the implant companies that manufacture all the spinal implants are billion dollar companies, multi-billion dollar companies. They have basically a stranglehold on the industry of spine surgery. And I grew up in that culture of doing spinal implants because what I saw was that the patients did really, really well. We can get rid of their pain with fusions and with putting implants in. We can stabilize and treat pain and neurological deficits quite effectively. So when I heard about endoscopic surgery for the first time, I laughed at it and I said, that's a joke. There's no way this stuff will work. And my wife told me, go learn. My wife, she was smarter than me, and she still is. But she told me, go learn, see what they're doing. So I went, and here I am now. It changed my whole life. It changed the way I practice medicine. So,
10 to 15 minutes heads up, doctor.
oh yeah, I'll give you 15 minutes. Don't worry. We're barely done with the first one.
You have another level.
Yeah, we have another level to do. We're out in the foramen right now. And I'm just being very careful because the exiting root is right here below the laser. And this is a bone spur right here on the exiting root.
Where?
Right there, that yellowish thing that I'm working on. The root is right there under that. That's the posterior ligament.
The blue is
The blue is the dura.
blue. Oh my God.
That's the dura right there.
Oh, blue. It looks blue from what you
It's
inject.
stained, yeah, from the dye. So I'm trying to remove this narrowing, this bone spur. And it's happening, but it's just very slow, and that's fine. That's the way it is. That's pretty much it.
You are so damn close.
Uh-huh. Well, we always are close with neurosurgery.
No, I mean the epidural.
Yeah. Oh, we're right on the epidural, right on the dura. I can see the dura in most cases. Watch that cable. Here's the contralateral side.
We have a question.
Yep.
One of the viewers asked, it's a question we get quite a lot. Does this procedure treat pain from spondylolisthesis?
Does this procedure treat pain from spondylolisthesis? The answer is yes. It sure does. Yep, because the pain from spondylolisthesis comes from the disc, not bone slipping. That's a big thing that people think, oh, my bones are slipping, that's why I have pain. That's not why you have pain. You have pain because of the disc between the slipping bones has a tear. And the tear in the annulus of the disc where the listhesis is occurring is the source of the pain. Thank you. Take. All right, I need the, we're done with the C6-7. We're going to move up to C5-6. And I'll show you how we do that. I need the dilator. Okay, I need the fluoro ready. So yes, this surgery will fix the pain from spondylolisthesis because the pain from spondylolisthesis is discogenic pain. As a matter of fact, I've operated on many, many patients with spondylolisthesis doing the laser surgery you're watching, and it works phenomenally well. Of course, I was skeptical the first time I did it. I thought, this isn't going to work. And the patient did not want a fusion, which is the traditional way to fix a listhesis. The patient did not want a fusion. And they said, I don't care, just do the surgery. I'm like, all right, but I give you a 60% chance of getting rid of the pain. And I did the surgery and the pain went away, 100%. So I was very surprised. I started to think, well, why would a listhesis pain go away with a disc surgery when I'm not stabilizing listhesis? And I did it over and over again, and I've done probably at least 400 spondylolisthesis Deuk laser disc repairs, and the pain goes away every single time. Without variation, it goes away from the disc, from that area. And so I realized after about 100 of them that shot that it's not the listhesis that causes the pain. It's the disc. Thank you. All right, so at this point, I'm keeping the dilator in. You can see it. I'm removing the working channel or tubular retractor. Is our patient still chemically paralyzed, right?
Yes, you can tell me if you want more.
No. I don't need more. I just thought I saw him moving, but it must have been Luis's belly pushing on the patient. All right, so shot. All right, so this is kind of the hard part of the surgery, especially in this patient because they got big bone spurs in the front. I literally have to migrate this dilator tip from C6-7 up to 5-6 along the anterior longitudinal ligament between the longest colli muscles. So let's do it. 2, 3, 4, 5, 6, 7. You agree we're at 6-7, right, Luis?
I agree, sir. Yes, sir.
All right, here we go. Shot. So I'm going to move this out into the front of the spine. Shot. And when I do that, I'm going to stay on the spine. Shot. And of course I have bone spurs. Good, I'm on. I'm out and on, shot. So now I got to make my way up, but I'm going to check my, to make sure I haven't moved side to side. Shot, AP shot. So I'm going to just hold this steady against the spine. And this is probably the hardest part of the surgery. And let me know when you're ready. Yeah, my shoes are still dry. You guys are awesome. Thank you. All right, so we're still midline. Really good. I'm going to slide north. Shot. I need to come to my side just a little bit. It's sliding. Shot. Because there's a bone spur there. All right, lateral. So I'm happy with our midline. Now I want to look at where we are relative to the disc, the front of the disc. Let's not do anything, folks, right now because this is the most delicate part of the surgery. Shot. All right, I got to get up and over that bone spur. Shot. This is not going to be easy. Shot. I need another AP. If anything, Dr. Calcarni, I may have you hold the neck in midline traction.
Sure.
But he's not really moving, so I'm okay. Shot quickly. It's a quick shot. All right, good. Go back to a lateral. Oh, yeah. I just felt it pop over the bone spur. Quick lateral. Quick. You got to move faster. Perfect. AP. So on the lateral view, we're right in the middle of the front of the disc, which is perfect. And on the AP view, if I'm in the midline, then we're perfect. Then we can start advancing the dilator. Yep, we're perfect. So go ahead and give me a lateral. Once I get back to the lateral view, I'm going to advance this.
You want to make sure the suction.
Perfect. I need the mallet. Shot.
Oh, I have it.
I'm sorry?
Shot. I just need things to be kind of quiet right now. Coker. Shot. AP. So I'm not going to go crazy hammering this in. I'm going to verify that I'm still where I want to be in the AP view, which is not too far off to the side. That's perfect. I love it. We're doing good. So I'm going to advance this to the middle of the disc, right there. I need a pipe cleaner, go lateral. I call it a pipe cleaner in honor of my father, who's a pipe smoker and a surgeon. Shot. Shot. All right, perfect. So I clean the tissue out of the end, and now we can do our second discogram. Now this is not an evocative discogram or a provocative discogram. This is just a structural shot discogram. In other words, I'm doing this discogram not to elicit pain or see if this is a painful disc. I'm doing this discogram to inject the blue dye so that I could stain the degenerated disc of the herniation so I could take it out. It helps me identify the annular tear that I need to debride, and it helps me identify the herniation. You can see the herniation right there. So in the if you follow the tip of the dilator to the right or backwards, you'll see a tent of dye, of dark material. That's tenting over the herniation. That's why we're here, because we're fixing a herniated two herniated discs in this patient's neck. But we're not doing a fusion. Shot. So our patient is a musician, right? And did not want to compromise his voice. And if he had had open surgery, 100% his voice will change. 100%, guaranteed. With this surgery we're doing right now, he has the lowest chance of affecting his voice. As a matter of fact, in 1,000 surgeries of laser endoscopic Deuk laser disc repair, I've never had a patient with their voice change. Coker, AP. So with ACDF, anterior cervical discectomy fusion, with artificial discs, total disc arthroplasty, patient's voices change because of the scar tissue from the surgery. Perfect. Let's go back lateral. So we've got about 20 minutes. 15, 20 minutes. Probably 20.
Okay, thank you.
Mallet.
So you're using the mallet to go through transverse,
Huh?
you're going through
Shot.
that bone?
No, no, we're not going through bone. We're going through the disc.
No, but mallet
Shot.
you're using,
The mallet is to go through the disc.
that's really, it's not like a sponge.
Oh, it's hard. The discs are hard.
I
They're
think
firm.
it's
Shot. Oh yeah. So you see the tip of the dilator is right in the herniation. It's perfect. It's the most perfect surgery in the world. Not this one in particular, but this whole technique of endoscopic
So you
Deuk laser disc
see
repair.
indentation.
Shot. Oh, that's the herniation for sure. Yeah.
That's how you know.
That's in the foramen and that's the herniation. Shot. You just want to make sure that you don't capture the dilator as you advance your tubular retractor and start advancing the dilator, because you'll go into the spinal cord and paralyze the patient. So I'm not going to allow that to happen. But a mallet is a much better way to advance metal in a human being than pushing with your hands. You push with your hand, you could suddenly release, you transfer that energy right into the patient, and then you can do some really big damage. So people think hammers are bad, but they're actually, when I first saw the hammer used in surgery, I'm like, my God, why are you hammering somebody's body? You know, that's dangerous, but it's actually safer to use the hammer than it is to push.
With the hand it must be very difficult also.
With the what?
Difficult to advance the
Oh,
metal.
yeah, you'll be like this and then suddenly, yeah,
Like
very bad.
arrows.
Yeah, would never do that. A mallet is actually a precise tool. You can deliver a very precise load of energy. No, keep the floor in for a second. One more shot. All right, perfect. So you can take it out if you want. All right, we're going to get started on the second disc. Look at number 2, 3, 4.
Nice on, please. 1 second.
No, it's good you guys are staying ahead of the game. Our irrigation, our suction. All right, good. Thank you. Good job, everybody. Case is going quite well. This is probably your first endoscopic spine surgery you've ever witnessed, I would imagine.
Me?
Yes.
Cervical, yeah. Oh,
Well,
you mean
lumbar.
saw
You
the
saw my lumbar,
the
right?
way, yeah.
But I mean cervical.
So now, minimally invasive center in Tampa, what do they do?
They don't do this. They just use minimally invasive as a marketing tool. There's lots of spine surgeons that use the word minimally invasive, but they don't do minimally invasive surgery. They lie to the public. They're just trying to get people to go there. There's unfortunately a lot of unscrupulous doctors, which is why I've lost respect for doctors. What do?
Yeah.
They do microdiscectomy. Same thing everyone else does. They just call it,
Small incision.
yeah, it's a 21 millimeter incision. Maybe 18 if they push it. My incision is 7 in the back and 4 in the neck. This is a 4 millimeter incision. This is true minimally invasive spine surgery. They can't do what I do. They don't even know my surgery exists, most of them. This is like a stealth bomber. People have never seen it before. They're like, what is that thing? It can't be that big of a deal, right? Yeah, actually it is a big deal. You just don't understand what it is.
So that's a piece of the disc.
Yeah, that's a piece of herniation. We're in the base of the herniation right here. This blue, I think it's overexposed. I need to pull it back just a little bit because I'm wedged at the opening posteriorly. This is a piece of herniation right here. We're literally at the base of the herniation, right? So if you think about the herniation like being like a mountain, right? Like K2 or Mount Everest. We're at the base. We're inside the base of the mountain, and we're removing the mountain from the inside up. That make sense?
Correct, yeah, thank you. So now the reason for, the pain happening intermittently is because it retracts and there's a debris like flying around. Is that how it is? It's not a single piece of disc, right? That gets squeezed out.
Oh, there's lots of pieces of herniation. There's more than one.
See, I think
There's fragments, multiple fragments. There's a piece right there. You see that? Right there. Literally right there.
Oh,
Great
yes.
stuff.
And it's coming out, okay, because of the irrigation.
I did not know that.
Oh, yeah. Yeah, most 98% of herniations are multiple fragments.
So is that why pain comes and goes?
Right here, the arm pain is coming from this right here. This stuff right here is pushing on the nerve. That's where the nerve is. It's underneath there. This stuff shouldn't be there. This is the herniation. I'm literally inside the herniation, taking it from the inside out. That's why this procedure is so beautiful. There's a piece of herniation right there. You see it?
Yes.
It wants to come, and I'm going to release it right there, and now it's coming. There it is. It's ready to come out. Yeah, it's a big chunk.
So what do you do with this chunk? Send for
We sent it to the pathologist.
uh-huh.
I missed it. Yeah, the pathologist then will, say
Examine.
herniated disc, degenerated disc, whatever. We have to feed the pathologist. They have a family. They need income too.
Correct.
Pathologists are the teachers of doctors, They're the ones who teach us in medical school.
Correct.
They're probably the most important besides the anatomy teacher. Yeah, I couldn't get it. So I'm going to have to release it a little bit more and zap it down with the laser. Show it who the boss is. There's another piece. But you can see the little chunks of herniation coming out.
Amazing.
Yeah, there it is right there. So I was taught at USC in Los Angeles. I was taught by the pathologist who wrote the pathology textbook for medical school. Dr. Chandrasoma and Dr. Taylor. Clive Taylor and Pakarama Chandrasoma. There was a reverse herniation right there. It just came out of the foramen. I'll tell you a little bit about me, since people like to know a little bit about who I am. The school at USC Medical School in Los Angeles is a 125-year-old medical school when I was there. And I graduated valedictorian, okay? So I had the highest grades of all students. And I made junior AOA, and I was #1 on the list for junior AOA.
Oh,
Alpha, Omega, Alpha. I was the president of AOA, the Honor Society of Medical School. And I was also #1. So, but let me tell you about pathology. Pathology is a year 2 class, second year. So you learn histology, you learn gross anatomy first year, and then you learn pathology. So the first year of medical school, you learn the human body as it should function normally, and structure and function that's normal through histology, physiology, and anatomy, okay? Year 2, you learn pathology. That's how everything goes wrong. The systems go wrong, the liver, the brain, all the diseases. The whole second year of pathology, there's a test at the end of the year, of the whole year. It involves histology slides and questions. And it's the whole day. I scored 100% on the pathology test final at USC. And I was recognized in front of the school as being the only student in the history of the medical school to ever score a perfect score on the final exam. It tells you a little bit about me.
I think you're kind of smart.
I'm kind of smart. Actually, I'm not so smart. I'm more hardworking.
No, you.
There's a herniation that just came out. Beautiful.
Curious cat.
I don't settle for anything less than the best.
I think curiosity and learning.
Yeah, of course.
Highly motivated.
There's another herniation. Look how smooth it is. That's from chronic inflammation. Smoothing it out.
So this is the worst herniation between the two.
I think they're both bad. I don't know. Maybe this is more pieces. I think maybe some more pieces.
So now you're going higher up. 2 weeks from now, right?
Higher up.
On C1 or C2 something?
I
Stage?
don't remember what you're saying.
No,
What are you
it's like
talking
the
about?
Second stage repair.
I don't
That's
understand.
Probably back.
Are you talking about another patient?
No, same patient.
Oh, or next on Thursday,
Yeah.
you're saying we're doing something different.
You're doing lumbar, I think.
Yeah, lumbar maybe.
And
Yeah.
then are you coming back to cervical at different level or no?
I don't know. I just show up and I do whatever the consent form tells me to do.
No, it's okay.
I don't think too much about it.
So now next week I'm not there, so I don't know who is covering for you. I'll talk to them about the.
What do you mean you're not there next week?
I'm going for an Indian wedding in Chicago.
Do they know that?
Who? Yes.
Because I don't think I have anybody else.
I thought he was coming next week.
Who?
This gentleman for his back.
Yeah, but I don't have an anesthesiologist that I know of.
I think she has asked Bauer, Dr. Bauer.
Uh-huh.
I'll talk to her about difficult airway.
Uh,
If you can make a note in your chart that
that what?
anterior larynx and difficult intubated.
This patient has an anterior larynx?
Correct. And he has very, very expensive upper caps.
Oh, really? Well,
And then the voice. So I tried to
I think you should tell Mike because Mike needs to remember that.
remember.
And expensive upper caps.
Expensive and the museum and the vocalist. Vocalist.
Vocalist, a musician.
W-R difficult.
Hold on. So the
Dr. Patel is good with the V's and W's. You know, Indians, we have hard time pronouncing V.
all right. Yeah, Dr. Patel does fine with it. So at this point, do we have any questions over there, Sean, from our audience?
Not at the moment.
Huh?
Just a moment.
How does a reverse herniation occur?
When the herniation comes back into the disc.
Is that just from like
Michael,
overuse?
Well, no, reverse herniation happens with surgery. It's the only place it happens.
Or when it goes back in?
Yeah. What about it?
I was just wondering how that occurs.
It just happens. The pressure on the disc herniation inside the epidural space pushes it back into the disc.
Okay.
Right? So pressure pushed it out. Pressure pushes it back.
is that how the pain gets relieved intermittently?
No.
So the disc can impinge on the
The
nerve
pain is from inflammation.
always, most of the time.
Always. I mean, unless you fracture your spine. And if you fracture your spine, you'll have pain, immediate pain from the fracture, from the periosteum. But then as soon as, an hour goes by or whatever, 15, 20 minutes, you get inflammatory response. Then all your pain is from inflammation.
I think you're right, absolutely, because I had stabbing pains and I took naproxen and gabapentin.
Yeah.
And
That's why we treat it with anti-inflammatories,
yeah, absolutely. Yeah.
because it's inflammatory pain.
That's totally, I thought it was impingement, but the fact that it got better.
Impingement of what? Your nerve?
No, it's like,
Yeah, everybody
Dr.
thinks.
Dr. Deuk, you know, right? Robert Deuk. He's the spine surgeon at UF. He came out.
He may have come after I left.
Yeah, he came.
What about him?
He's the one who saw my MR. I'm going to have them give a consent.
What do you say though? I mean,
No, he said,
there's a lot of misconceptions about pain.
yeah, he
A
said
lot.
herniation versus bone spur.
Well, it's probably both.
I
Everybody
was
has
in
bone spurs.
tremendous. I'm usually a good tolerant for pain, but this, I was crying, and the whole thing was so rigid.
You were crying from pain.
Yes,
And did the pain go away?
with the naproxen, gabapentin, and then physical therapy.
All right, that's good.
I know the fact that you said most of the time.
It's all inflammatory.
Which
It's not
I
most of the time, it's 99.9% of the
did
time.
not know that.
Yeah. All this pain is inflammatory. Knee pain, hip pain, muscle pain. Every pain is inflammatory. Virtually every single pain is inflammatory.
So the nucleus is what causes.
Yeah, the nucleus pulposus is pro-inflammatory. It promotes inflammation, right?
Why?
Why? because that's what God wants. I don't know. God designed it, not me. But the nucleus...
As a warning, did he do that for?
No, I think the nucleus is considered a foreign body by your inflammatory system, right? So it's seen as not me. It's seen as foreign. And anything foreign in the body elicits an inflammatory response as long as your inflammatory system is working, which we're not talking about an immunological system, we're talking about an inflammatory problem.
So about 10 minutes, doctor?
Yes, 10 minutes.
We have another question. What do you do once the herniation is removed? What is the healing process like?
All right, well, once the herniation is removed, the body will heal. The problem is the body's trying to heal the herniation, but it can't because there's too much jelly wedged in the annular tear. So I have to remove and debride the annular tear by removing the interposed nuclear material that's preventing the annulus from healing. Once the annulus heals, your problem is resolved. So I'm promoting natural healing with this surgery. That's the whole surgery. I'm allowing it to heal by removing the herniation and debriding the annular tear. And as I said before, the Deuk laser disc repair is the only surgery in the world that does an annular debridement to promote healing of the annulus. It's because I'm the only person who really understands the annular tear is the source of pain. Other surgeons that do spine surgery, nobody else knows that. They all think the problem is a pinched nerve. That's it. That's all they think about is a pinched nerve or pinched spinal cord. They don't think about inflammatory pain. And they don't think about an annular tear. You never hear anyone talking about an annular tear. If you go to all the meetings, I've been going to meetings for 22 years now in neurosurgery. In 22 years of going to the top meetings in the world for spine, you never hear a single surgeon talk about the annular tear because they don't know about it, they don't care about it, they don't think about it, they don't realize how important it is in a generation of pain. But I do. I figured it out by doing these surgeries. Doing these surgeries was the only way I figured it out. So what I'm doing is I'm cleaning this stuff up right here. All this grunge from chronic inflammation. And I'm letting this patient's disc heal itself. I'm letting it do what it's wanted to do for years. It just hasn't been able to do. So people with herniated discs and neck pain or back pain, the pain is coming from the disc trying to heal itself. It's coming from inflammation within the disc as the disc tries to heal. That's why if you injure yourself, like a soft tissue injury or a fracture, it hurts for the first week or for first few days to a week. It's hurting because your body is doing inflammation to clean up the injury. And then it stops the inflammation after about 3 to 5 days, and it starts to do the repair, where it brings in the repair cells like fibroblasts. Well, this disc here, the body has been trying to repair it for a long time, and it hasn't been able to. So I'm coming in with a laser, and I'm giving it now a chance to heal. That's what the Deuk laser disc repair is. I'm removing these chunks of herniation. So if there was a pinched nerve, we're getting rid of the pinch by removing the herniated fragments like this one right here. And by removing this stuff and cleaning up the annular tear, I'm allowing this patient's disc to heal naturally, without fusion and without artificial disc. And this is a much better surgery than fusion or artificial disc for many reasons. The most important of which is the results are better than any fusion or artificial disc in the world. There is no fusion surgery or artificial disc surgery result that's better. Not even close. Those surgeries get maybe 50% relief on average of pain. Our average is 95% relief of pain. By the way, the nerve root is right here, right there. So I'm looking in the foramen on the patient's left, and I don't see any herniation anymore. There's this little herniation right here, no big deal. It's more central, getting rid of it. Plus, this surgery here, we don't put any implants in. So there's no charge for any implants. Spinal implants like screws, rods, cages, they can cost as much as this whole surgery costs just to do the entire surgery for those implants. So this is a much more cost-effective surgery. It saves money. It's safer for the patient. We've had 0 complications in 13 years. It's more effective at getting rid of pain, 95% relief of pain average. Yes? All right, watch out. We're almost done. We need just another minute.
Toradol is okay, doctor?
What is it? Toradol is fine.
Ketorolac.
Yep. Yeah, it's fine. Yes, it's fine. So there's absolutely no reason to have a fusion done anymore. You just need to come to Deuk Spine Institute. So just for the people out there who think I don't know how to do spinal fusions, I need irrigation. Actually, I grew up on spinal fusion, so I do spinal fusion better than anybody out there. I guarantee it. I've done 1,000 anterior cervical fusions. I've done about 450 posterior cervical fusions. And I've done over 1,000 lumbar fusions. So I know how to do fusions, and I do them very, very well. As a matter of fact, I've published my results in the National Library of Medicine in the United States. My results are so good. You can look up transforaminal lumbar interbody fusion by Dr. Deuk Majin, and you'll see we have the best results for fusion. So why would I do this surgery if my fusion results are so good? Because this is a better surgery for patients, that's why. And it really comes down to not what's good for me, it comes down to what's good to my patient. And I get paid more with fusions, but the reality is a fusion is not a better surgery for patients. This surgery is. So I always recommend what's best for the patient. So my dad taught me to do. And I've had great results as a result. Okay, we're done. We've decompressed both foramen, 5, 6, 6, 7 on the left side. I don't see any further fragments. I just see dura and nerve root. We're done. So for those of you watching, this has been a live surgery. And today is what? November 5th, 2019. I'm Dr. Deuk Majin, the CEO and founder of Deuk Spine Institute. I'm here with my team. And this patient has just had 2 herniated discs in their neck, fixed without fusion. And take a look at this thing, folks. Let me have that. Look at the incision here. Give me a second to apply pressure. Take that. All right, so Sean, can you see over here?
Yes, we can.
I'm going to show everybody the endoscopic rig. Let's look at this first while I apply pressure. Can you see the endoscopic rig? Now
Yes, we can.
we've done this for the lumbar, but not the cervical. So the camera is here. It attaches to the scope right here. The scope is this part. This is the laser fiber. It's a 0.5 millimeter fiber. This is our irrigation. This is our light source we looked at before. And this is the cervical scope. Yes, it's by Richard Wolf. They're in Germany. This is all FDA approved. Everything we do is FDA approved equipment and drugs. Yep, that's it. Oh, go ahead and get it out. All right, now go ahead and take a look at the neck here. Look at the incision. Can you guys see this incision? It's literally 4 millimeters.
I don't see it.
It's right there. 4 millimeters. The neck is supple. There's no hematoma. And our patient's going to do fantastic. Huh?
His pain is super, but this is after that if you take some more local.
Oh, we don't need more local.
That's awesome.
Yeah, it's an incredible surgery.
Leave today, can you examine my neck?
You have $10? Just kidding. I'm not that cheap.
I don't have a team for
Of course I'll examine your neck.
and I'm gonna have them send the MRI.
Where's my hammer? I need to examine her neck. Just kidding.
Do we recycle those gloves?
Those you do, but not those. They're ripped up a lot. All right, so I'm going to head over to the conference room and answer some questions. We did have a posterior cervical laminectomy infusion set for today, but our patient unfortunately took some aspirin, so we've canceled that surgery and moved it over to Thursday. So Thursday, if you're interested, you can watch a posterior cervical fusion. And you can see the kind of fusions that I do. All the fusions are done outpatient. And patients usually go home within 2 hours of their surgery. This patient will be extubated and go home an hour after they're out of here. I'm going to call our EBL $500,000.
No, actually, you're right. What are you gonna say?
All right, so if it's $500,000, then according to you, it double it, so we'll do 1 mil.
Oh, too easy.
No, 1 mil.
Okay.
All right, right approach.
So now why doesn't this get reimbursed by Medicare?
Why don't some insurances want to pay for it right away and you have to fight them? Because insurance companies are scum and all they want to do is keep the money that you give them as premium dollars. They don't want to pay for anything.
They have to give less money for this, right?
Yeah, but they don't want to give any money for it. Why give any money if you don't have to give any?
How about private insurers?
We have some that do.
Okay. Because this is the cutting edge.
This is the best surgery in the world. It's got the best results for herniated discs in the neck and back. All right, I'm going to head over and answer some questions in just a minute.
Learned a lot today about my neck.
Okay, hello everyone. Dr. Deuk here. Hopefully the mic is coming through okay. You have just watched the most advanced spine surgery in the entire world available to treat a painful or symptomatic cervical disc herniation. That means if you have neck pain, you have a pinched nerve going down your arm with pain, numbness, tingling, or weakness, we call those symptoms radiculopathy, then you've just watched the most advanced, best surgery available in the world for patients with symptomatic disc herniations in the neck. And also the back, but we didn't do the back today, we just did the neck. So why is this surgery so amazing? The reason is simple. Number one, the results are better than any other surgery out there, whether it's a fusion, artificial disc, laminotomy, laminectomy, whatever. It doesn't matter. I've done them all. I've done them all hundreds and hundreds of times. I do those surgeries quite well, and my results are really literally at the top for fusion surgeries and decompression surgeries. And this surgery you just watched, the Deuk laser disc repair, the results are off the chart. I mean, they're literally the best in the world. 95% relief of neck pain, 95% relief of arm symptoms. Those are averages, by the way, for all of our patients having the procedure. And 95% relief of headaches that come from the neck. These are not migraine headaches, obviously. These are what we call cervicogenic headaches. Cervical means cervical spine. Genic means genesis, or originate from. So these are headaches that originate from the spine. Okay, these are people with herniated discs that have a inflammation in the back of the disc that you just saw us repair, and that inflammation gets on the dura, which you saw there when I was done. It was stained blue, and it leaks out on the dura, and the dura wraps around your head, and of course it causes headaches. So cervicogenic headaches, neck pain, and arm symptoms from a irritated or pinched nerve. The Deuk laser disc repair, only available in the United States, only available at Deuk Spine Institute. So I would recommend for anyone listening, you consider downloading our Deuk Spine Institute app on your cell phone. We have an Android version and we have an Apple iPhone version, iOS version, and they're free. So if you go to your app store and you type in Deuk Spine Institute, that's D-E-U-K, Spine Institute, you'll find the app, download it. It's got great content, literally probably the best spine app in the world. It has testimonials, it has videos of surgeries, whether it's fusions, artificial disc, laser surgery, endoscopic surgery. Pretty much you have access to our entire surgical archive. And we do video and broadcast every single surgery we do at the Deuk Spine Institute. Of course, we don't do the pain management procedures because they're boring. I'm just kidding. But because we could do them, but we would need more programming funding available. And since we haven't had Mark Zuckerberg or the Jeff Bezos donate any money to us for our foundation, we don't have any money in the foundation available to do any programming. So what you're seeing right now is our educational content, and we do the best we can. It's better than pretty much everybody else out there anyway. But we're providing educational content to you, the viewers who are watching these videos. And the purpose is, number one, teach you about what really happens in spine surgery and teach you about state-of-the-art information, what's known, what causes neck pain, what causes back pain, what's a herniated disc, how does it cause pain, what happens with a pinched nerve, how do you fix a pinched nerve, how do you fix a pinched spinal cord, is fusion necessary, what happens with fusion. It doesn't matter what the topic is, as long as it's related to medicine, we discuss it here. We don't talk about politics, we don't talk about pretty much anything else except maybe coral, since I'm a coral researcher as well, and we don't talk about anything else except maybe racing, since my son is a national champion go-kart driver and looking to a career in Formula One. So, and of course my daughter, who is a national champion dancer as well. So dancing, maybe some soccer, but really the most of it's going to be spine. And I'm happy to answer questions. If I don't know the answer, I'll just tell you I don't know the answer. I'm not here to lie to you. I'm just going to give you facts. There are people who won't believe what I say, and that's fine. You're entitled to your opinion. But in the end, who's talking to you is a board-certified neurosurgeon who's literally valedictorian of high school, valedictorian of medical school, and trained at one of the best neurosurgery training programs in the United States of America and hence the world. And of course, I spent the last 22 years focusing on spine. So if you don't agree with me, that's perfectly fine. Like I said, you're entitled to your opinion, but as long as I'm paying for the programming, I get to decide what's said and what's done. So we have questions from our audience, and I'm going to answer them. And sometimes you'll hear me kind of go off on a tangent. And the only reason I do that is because I usually want to discuss kind of some of the nuances. So everyone's really exposed to, I would say, a very narrow range of information regarding spine care. When you go to your doctor or you go to the internet, you Google, you find very limited amount of information about specific topics. And I hate to say it, but a lot of it is just cooked and contrived and not true. It's really more opinion and limited opinion. If you want to know about space travel, you talk to an astronaut. You know, if you want to know about what's it like to work outside the space shuttle, the International Space Station, to do a spacewalk, you know, you talk to an astronaut who's done it. And the problem is there's a lot of people who would like to be astronauts, but they're not, and they're willing to share their experiences as though they're facts. And so if you want to know what the most advanced spine surgery in the world is, or most advanced spine care, or what the current knowledge is of spine issues, then you go to somebody who's an expert in it, like myself, and you get information from them. And I'm willing to share that information to the audience. And I'll tell you, one of my goals is to really educate everybody so we all get on the same page about what can be done about neck pain and back pain, what are the best options, what has the highest risk, what has the longest duration of effect, what's going to work longest and permanent for you. And by the way, one of the reasons I do this show is because I see so much bad spine care being given out there. I see so many bad surgeries, bad procedures that shouldn't be done, that are done incorrectly, and the patients suffer as a result. And that's really what drives this entire discussion. This is what drives my show, is I don't want to see people get bad medical care. I don't want to see people suffer needlessly, unnecessarily. I don't want to see people get complications from spine care that they didn't need to get. I don't want to see people get metal put in their body they shouldn't have put in. Those are things that bother me, and they bother me enough to do something about it. So that's why we have this program, is so I can do something about it, and I do it through educating people and answering your questions. So without further ado, I'm going to take the first question. Sean will pose the first question.
The first question is a patient who says, I had fusion at my C6, C7 vertebrae and the operation took 4 hours. Is that a normal length of time for it to take? And it relieved the pain in the area, but I'm still experiencing tingling, numbness, and pins and needles in the joints down my left arm. Is that also normal? And is there anything I should ask my surgeon when I see him tomorrow?
So our first question is a fantastic question, and I appreciate one of these people out there in the audience sharing their experience. It's really good to learn from people's experiences because they're real-world experiences. So the first question was, I had a fusion done at C5-6, and correct me if I'm wrong here, Sean, right? Fusion done at C5-6 in the neck. Sorry, C6-7 in the neck. And this patient's surgery took 4 hours. So is that typical? Yeah, I would say that's typical for the average spine surgeon. That surgery would take me 1 hour to do, or 45 minutes. And that's only because I feel very, very comfortable with the anatomy and I know what I'm doing and I do a very good job. But the average spine surgeon is not able to do the surgery faster than, say, 3 to 4 hours. That's pretty common. So I don't think that anything happened bad necessarily based on the amount of time that it took them. That's pretty standard. Now, in answer to your question, if I still have numbness and tingling in my arm, down my arm in the joints, that's not normal. It's normal to have numbness after a decompression of the nerve root that's been pinched for a long time. It's normal to have some numbness, but it's not normal to have the tingling. And if there's still pain going down your arm, that's not normal either, in my opinion. All right, not in my patients. So if the surgery is done well and the nerve is unpinched well, then you should have relief of your arm symptoms minus some numbness. So here's what I'm going to tell you about this type of surgery you had. It sounds like you had an anterior cervical discectomy and fusion. There's about 200,000 of those surgeries done every year in the United States alone. They're done by neurosurgeons, they're done by orthopedic surgeons. There's a big difference, in my opinion, as long as you have a good neurosurgeon, there's a big difference in how the surgery is done. Most orthopedic surgeons will not take the herniation out that you saw me take out today endoscopically. They'll leave it because it's too far back in the disc and they can't see it. So they just kind of scrape around a little bit with their scraper and they take the front of the disc out, but they don't take the back out where the herniation is. That's exactly opposite of what should be done, and it's the opposite of what I did today. I left the disc the normal disc in the front alone. I left that whole disc there. I just took the little piece in the back that was pinching the nerve out, that was causing the neck pain and causing the arm symptoms. That's what your surgeon needs to do. If you're having an anterior cervical discectomy infusion, your surgeon must get rid of the herniation that's in the back on the side of your arm symptoms and pinching it. And if they don't do that, then they haven't done the surgery properly. They haven't done a decompression at least. Now, here's the truth. Most orthopedic surgeons just do a fusion. They don't really decompress. They don't take that herniation out. They're too scared to. They're not trained properly to. They're too scared to. They don't have the skills. They don't have the knowledge. They don't have the experience to do it. So if you go to an orthopedic surgeon for your neck surgery, chances are you're not going to get the right surgery done. I mean, when I say chances, I mean about 95% of the time. On the other hand, when you go to a neurosurgeon, probably about 50% of the time you're not going to get the right surgery. Because, yeah, there's a lot of bad neurosurgeons, too, out there. They don't know what the hell they're doing. I'm going to be honest with you. Let me just digress for a second here. When I did my residency application from medical school, neurosurgery is the hardest residency to get into. It's the most competitive. It only takes the brightest and the best in medical school, okay? Now, there's 100 neurosurgery programs. At least there were when I applied. Nowadays, there's about 120. But each neurosurgery program that trains neurosurgeons for 6 to 7 to 8 years, average is 7, they take literally the best that they can get, right? But not all neurosurgery training programs are equal. And, you know, somebody may say, oh, you're just saying that. No, I'm not. Let me tell you why I know that. I went to USC Med School, University of Southern California. USC was very, very special for neurosurgery, and I'm going to tell you why. The chairman of neurosurgery at USC is a man named Dr. Marty Weiss. Marty Weiss. And Marty Weiss is an older neurosurgeon, but more importantly, he was world-renowned, and he was very politically active, and he was an exceptional surgeon, and he was the chairman of the Residency Review Committee. This is a very important organization. It's basically a bunch of top neurosurgeons that go around and check on the 100 neurosurgery training programs to make sure they're training the residents appropriately by giving them the right educational experience, didactic teaching, and surgical experience. So Marty Weiss had all the statistics for every neurosurgery program in the United States. And let me just tell you something. The list of top programs that gave great training was about 20 out of 100. The other 80% sucked. So I'm sorry if you went to a shitty neurosurgery program, you should have studied harder. But long story short is that 80% of the neurosurgeons, in my opinion, from my experience working with Dr. Weiss, really aren't trained as well as they could be. And the top 20 programs gave great training, great experience. I mean, it comes down to faculty, it comes down to caseload, the type of cases, and the availability of those cases to the residents during training. Fact of the matter is 80% of the programs pretty much suck, and the neurosurgeons coming out of them aren't magically going to know how to do really good quality surgery on their own. They have to be taught. And I can tell you, from interviewing lots of them that have graduated their programs, they all think the same thing. They all think they know everything. And when you come out of a bottom 80% neurosurgery training program in the United States or anywhere in the world, your knowledge is not adequate to really do the best for a patient. So you're going to get shitty results. So this person who's asking about, well, I had a 4-hour surgery on my neck with an ACDF and I still have symptoms in my arm. It doesn't surprise me. And it's not because the surgery was done properly and you just have a problem that won't go away. It's because your surgery, and I don't want to throw your surgeon under the bus, but maybe your surgery could have been done better. And when I say that, here's what I mean. It's possible that you have a disc herniation above your fusion, okay, that was unaddressed, not done, wasn't taken care of at the same time, aka you're going to need a second surgery. This is a very common thing. So why does this happen? Why would a surgeon only fix one disc when the patient needs 2 fixed? Number one, time. They don't want to spend more than 4 hours in the operating room like your surgeon spent, and they don't want to spend 6 or 8 hours in the operating room to get paid $1,000. They really many of them just don't have the ability to do 2 discs. Maybe their hospital won't let them. Maybe they don't have the equipment available. Maybe they don't have the time. Maybe they don't have the interest. I mean, there's a lot of excuses, but in the end, they're all excuses. And the truth is if you had 2 herniations that need to be fixed, you should have fixed them both. You saw the patient I did today. I did 2 herniations. Why? Because they needed both done. It's not because I want to do 2, it's because they need to. And if I don't do 2, they're going to end up still having neck pain or arm symptoms at the end of the surgery. I see this so often in other surgeons' patients where they undertreat the patient. They only do 1 disc when they should have done 2 or 3. If you ask me what my average number of disc herniations that I fix with 1 surgery is on a patient, it's 2.5. So that means that most patients are going to have between 2 to 3 disc herniations fixed with surgery when I operate on them. And that's probably one of the reasons why my results are so good, why I'm able to get rid of 95% of patients' neck pain, headaches, and arm symptoms with surgery, 1 surgery. And that's because I treat all the discs that need to be treated. I'm not afraid to do 2. I'm not afraid to do 3. I'm willing to take the time that it takes to treat the patient and do the best for the patient. 80% of the surgeons out there are not that way. They just want to get in, get out, and they want to, maximize their revenue stream and minimize the pain and suffering of being in the operating room operating. I actually enjoy being in the operating room. All right, so what should you talk to your surgeon about? I would just say, why do I still have these symptoms? And what you really should be doing, though, is don't waste your time with your surgeon. Send your MRI into Deuk Spine Institute. Deuk Spine Institute will take any MRI of the neck or back from any patient around the world. We don't care if you have no insurance. We don't care if you don't come see us or not. We will be happy to look over your MRI. We'll be happy to do a 5-minute video chat conference with you. You have to arrange it through patient services. And be happy to talk to you about the findings on your MRI and what can be done to help you, what you should and shouldn't do. Okay, you don't have to actually come here and get your care, but we want to give you advice. We want to get you on the right path. We want to make sure you don't go out and get hurt. And that's really our goal. So if you want help, you want real good advice on your spine, then get the Deuk Spine Institute app, download it on your phone, and fill out the free MRI evaluation. And send your MRI in. Send a report in, send the images in, and let me look at it. I personally review every single free MRI review that comes to Deuk Spine Institute. I, Dr. R. Deuk Machen, CEO, founder, head neurosurgeon, check every single one of them out. I personally do all the video conferences that are free at this time in 2019. Now in 2020, we may eventually you have to pay money to do a video conference. It won't be much, $40 probably, but right now it's free. But I'll be honest with you, what we get reimbursed and what we collect money-wise, barely enough to cover our overhead. So we're not making a killing here, but we're providing great medical care to people at an affordable rate. We're trying to keep it that way. So I've paid off all my loans. I'm in a position financially where I'm very happy. I don't need more money, but at the same time, I want to help as many people as I can. So that's why we have these broadcasted surgeries. That's why we do surgery. That's why I haven't retired yet, even though I could go off and live in the beach somewhere. I stay here to help people and spread the word and educate the world about what can be done to help them. So my advice to you is talk to your surgeon, and ask them why you still have the symptoms. But in my opinion, the only thing you should have is numbness, and numbness can sometimes take up to a year to go away. And then turn around and get a copy of your MRI, download the app, Deuk Spine Institute app on your phone, submit your MRI for a free review. Next question, Sean?
The next question is, I have a herniation in my neck, and my surgeon has told me it's impossible to operate on my cervical spine. Why would this be?
All right, so first of all, impossible to operate on your cervical spine. You have a herniation. So first of all, thank you for sharing your experience again. And I thank every single person that asks a question, makes a comment, because that's really what this is supposed to be. I can't teach as effectively by myself without your input. So thank you. Yeah, your surgeon says it's impossible to operate on your neck. I mean, I've never in my entire career or my life have seen somebody with a neck that's impossible to operate on. So that statement in and of itself is 100% false. Now, is it possible that you've had, you know, a horrible injury to your neck and that you have like radiation in the neck from thyroid cancer or something and your whole neck is scarred up and you can't get to it through the front? Yeah, well, then you just go through the back of the neck. No big deal. So I can't think of any situation in the world that exists that would keep you from being able to fix your herniated disc. But what you're saying to me is something I hear all the time from patients. My surgeon says that surgery is not possible. My surgeon says that it's just arthritis. Learn to live with it. My surgeon says there's no reason for your symptoms. Just go do physiotherapy the rest of your life. I mean, I can't tell you how many patients I hear from that are told there's nothing that can be done for various reasons. And they're all wrong. They're all made up. They're all concocted. But the truth is that your surgeon may not be able to fix your problem because they may not have the skill or expertise to do so. That's very common. And so instead of saying that to you, hey, I don't know how to fix your neck because I'm not a very good spine surgeon, they're not going to say that. So they're going to say to you, your neck's not fixable. You know, you got a problem with herniated disc, there's nothing that can be done. And I hear these lies and lies and lies day in and day out to patients. And the fact of the matter is that your surgeon may not be able to fix your neck, but that doesn't mean someone out there can't. And of course they can. So my advice to you, send your MRI in for a free evaluation at Deuk Spine Institute. Download our app and the App Store, DeukSpine.com. I'm sorry, Deuk Spine Institute, and you'll find that we don't charge for the app. It's free. So we don't charge for the MRI review. It's free. We don't charge for a 5-minute video conference. It's free. So you should do all those things and get a second opinion is what I'd recommend. Next question.
Our next question is, are there any weight restrictions or health restrictions that prevent you from doing DLDR?
All right, one of our viewers is saying, hey, Dr. Deuk, we like this DLDR procedure, but are there any like restrictions that would prevent you from being able to do the surgery? The answer is yes. Okay, so with respect to the cervical spine surgery that you just watched, the kind of things that would prevent me from being able to do surgery, there's a couple. One of them is somebody with a really thick neck is just not safe. But it would be like really thick. It'd have to be 95th percentile and bigger. Like we're talking super thick neck. Then it's not safe. I wouldn't do it. But I can still do an open incision, get down to the spine, and I can do the laser surgery on the spine. So you wouldn't have to have a fusion, but you'd have a bigger incision. So that thick neck situation can be remedied by an open exposure to the spine and then doing endoscopic at the spine. So it can still be done without fusion. The next situation would be a high collarbone. So if you have a really short neck with a high collarbone up front, I can't get to that disc at C6-7 because of the high collarbone. Today's patient, I was able to get to C6-7 easily. But there are patients with shorter necks that have a C6-7 lower disc herniation. I can't get to them because of the high collarbone. There's no way around that. It's impossible. And you don't know until you get them in the operating room, and unfortunately you find out at that point. We had a patient like that about a week or two ago that had 3 herniations. I couldn't get to all 3. I couldn't get to the bottom one because their collarbone was too high. So I could only do the top 2. And the patient had pretty good relief. Their entire left arm was normal at the end of surgery. They had both arms bothering them, but their right arm was still bothering them because that was the bottom disc, C6-7, that was causing those arm symptoms. So high collarbone, super thick neck, and then there's always, if you've had lots of surgery in the front of your neck before and there's tremendous amount of scar tissue, then I can't safely do the Deuk laser disc repair. So for the lower back, there's almost no situation I can't get to it except for L5S1 sometimes due to anatomy. Now, as far as size of the patient, like weight, I would say we can safely do surgery up to about 400 pounds. So if you're having problems and you're over 400 pounds, we may still be able to help you, but I doubt it will be with laser surgery. Hopefully I answered all the questions there. Next question, Sean.
Another similar one. My surgeon says that because my pain doesn't radiate into my arm, that the herniation on my cervical spine doesn't qualify for surgery. What are my other options and how do I qualify for surgery?
All right. Thank you, Sean. The question that you just heard is such a common scenario. That's why one of the reasons why we broadcast this show. And that is this. I have a herniated disc, but I don't have arm symptoms. So I have neck pain, but my surgeon says I can't have surgery because I don't have arm symptoms. That's correct. Most spine surgeons are very limited in their understanding of herniated disc and how they cause symptoms. That's one of the reasons we do the Deuk laser disc repair. With the Deuk laser disc repair surgery you just watched, we can fix neck pain in patients that don't have arm symptoms by repairing the herniation. So your surgeon is correct. You would not qualify for a fusion surgery, and you may not qualify for an artificial disc surgery if you don't have arm symptoms. But you do qualify for the Deuk laser disc repair. The Deuk laser disc repair surgery, the endoscopic surgery you just watched, would be able to fix your neck pain when you have a herniated disc, even if you don't have arm symptoms.
All right, and our final question is, I have a small bulge in my lumbar spine, L5-S1, causing me a lot of nerve pain, but my friend who has a huge herniation in the same region barely has any symptoms. Why is my nerve pain so much more severe?
Okay, so again, great question, and every single question that's been asked has been phenomenal and really good teaching point. So this is a person who has a small disc herniation on MRI, characterized as small, like a disc bulge, and they're like, why is my pain horrible in my back and going into my leg compared to someone else I know who has a huge disc herniation, and they have almost no symptoms? You have made my point. My point is you can never look at the size of a herniation and gauge how much symptoms a patient should have. This is a mistake that most every spine surgeon makes. They say, oh, small herniation, you don't need treatment. Oh, big herniation, you need treatment. No, what you need to look at is the patient and the symptoms they're having from the herniation. I don't care how big the herniation is. I care about what symptoms my patient has. If the patient has a ginormous herniation and no symptoms at all, we don't operate. We leave it alone. Go out and live life. Enjoy life. Do what you want to do and don't worry about it. On the other hand, if you have a small herniation, horrible pain in your back and leg, you need to get it fixed surgically. That's it. Surgery is pretty much the only thing that's going to work. But I'm not talking about the other kind of surgery that's available, laminectomies and stuff, because they won't work. I'm talking about Deuk laser disc repair. You specifically will need a Deuk laser disc repair. That will fix pain in your back and leg from a small herniation or a disc bulge. That's what we specialize in fixing, folks. The endoscopic surgery, the Deuk laser disc repair, fixes back pain from a small herniation or disc bulge. Other surgeons won't touch it because they can't fix it with technique that they have. But we can fix it with the endoscopic Deuk laser disc repair. Well, hopefully that clears things up, and it sounds like that's our last question. Is that right? So, again, I'm Dr. Deuk Majan. You've just watched a cervical, which is the neck, Deuk laser disc repair. It's an anterior transdiscal endoscopic, full endoscopic, laser-assisted annular debridement and discectomy to treat a patient with neck pain, arm numbness, weakness, tingling, and preserve his voice and not have to do open surgery and do metal or cages, which would definitely mess up his voice. So our patient hopefully will be a very happy patient when he wakes up. I expect him to be awake now and probably ready to go home soon. So stay tuned. If our patient's willing to share his post-operative experience with you today, then we'll do a quick video live stream from the recovery room as the patient is getting ready to go home. Generally, these patients that have the Deuk laser disc repair go home within 30 minutes to an hour after the end of their surgery. It's outpatient. You need to have a driver take you home, but generally people leave here with a pain level of a 1 or a 2 when they leave after their surgery. All right. I don't have anything else to add, Sean, do you?